Risk Assessment Project by Arely Velasco. Medical assessment. My patient is a 21-year-old female, white adult. She does not have any past surgeries nor conditions diagnosed. Her vitals were 110 over 65 millimeters of torr. Her respiration was 60 respirations per minute. Her pulse was 88 beats per minute. The patient is currently taking 100 milligrams of spironolactone for acne. She takes it every night, therefore that puts her as ASA2. Other than that, she does not have any other conditions that we should be aware about. For spironolactone, she uses it for acne. The pharmacologic category is an antihypertensive diuretic. It does not have any effects on local anesthetic. It doesn't have any effects on bleeding nor dental treatment. For adverse reaction, it doesn't have anything over 10% that we should be aware about, but dermatologic, it does cause rash, itchiness, and Stevens-Johnson syndrome. For mechanisms of action, it competes with aldosterone for receptor sites in distal renal tubules, increasing sodium chloride and water excretion while conserving potassium and hydrogen ions. The patient does not suffer from any of the side effects that mentioned. For extraoral examination, the patient did have some slight deviation to the left when she was closing. She does have some clicking and popping occasionally when she has long dental treatments or has active use of her jaw. Her oral habits is that she occasionally clenches during the day. And for angles classification, her right canine is class 3, molar class 1, left canine class 1, left molar class 2. Maximum opening 58 millimeters, facial profiles magnetic. Other than that, everything's within normal limits. For her intraoral examination, she is an overjet of 2 millimeters, overbite 3 millimeters. She does not have tooth mobility nor recession. For gingival description, everything seems healthy. It's pink, firm, stippled within the maxillary, free and attached. For attached, we see the stipple, we see the firmness on the free as well. She does have some localized blunted areas on her maxillary anteriors from canine to canine. Same thing from her mandibular anteriors, canine to canine. We do see the row borders slightly on number 24, mesial surface. From there, she does have regular knife edge. And between number 8 and 9, we do see some bulbous tissue right there, which we will get more into detail once she has that bulbous tissue. For her radiographic x-rays, we do have a panoramic image and some bite wings and PAs. We do see a lingual bar in her mandibular anterior teeth. We do see that the patient also has an implant installed. From there, her pulp cavity, alveolar bone, lamina dura, alveolar crest, everything seems within normal limits. We do see some slight horizontal bone loss, but it's nothing too drastic that we should be aware about. For anodontia, anodontia is a hereditary absence of primary or permanent teeth. The teeth that most commonly fail to erupt are those that erupt in the vital terminal areas of the dental lamina. The most commonly impacted teeth are the maxillary lateral incisors, second premolars, and third molars, which is exactly what my patient has. She is missing tooth number 4, 7, 10, 17, 23, and 17. As we see, tooth number 4 is a premolar, tooth number 7, 10, 17, 23 are lateral incisors, and number 17 is the third molar. It's amazing, right? It's crazy how this is hereditary because the patient does have her mom and her twin brother and her other brother who are also missing their primary and dental and permanent lateral incisors. Amazing to know such a thing can occur. Another thing I noticed within the patient is that she does have a frenectomy, which is the bulbous that we saw in her maxillary tissue. Her frenectomy is an excision of a frenulum left to heal by secondary intention. There are two kinds. There is the lingual frenectomy and there's the maxillary labial frenectomy, which is what my patient had. She had the frenectomy to help separate the frenum from that area so she could have better opening. And also, she did have a big and bad diastema So having that frenectomy definitely will close that space. It's still there very slightly, but it's better than what it looked before. This also helped the patient's well-being, not only appearance-wise, but also prevented raising the risk of gum disease and other dental complications. For periodontal probing, everything was great. Numbers were 2 to 3 millimeters. We did notice some furcation on tooth number 2, 3, 5, 18, 19, and 30, which were all buccal furcation class 1. Nothing so serious, but it's something we want to keep in mind as well. For her plaque index, she did have a score of 82.29, which is fair for her oral hygiene. Marginal bleeding index was 33.33, which is okay as well. We want to make sure we want to reduce those numbers. For her AAP classification, we identified her as gingivitis dental biofilm induced. This is due to the biofilm deposits with low levels of destruction. Also, the presence of that lingual bar is a local factor for biofilm, which puts the patient at risk. The furcation on the patient's molar are buccal class 1, so just now put her on a later stage for periodontal disease. For our treatment plan, we want to treat her in 3 different appointments. Appointment 1 will be scaling the right half of her mouth. She'll be flossed. We will be going over oral hygiene instructions to see if we need to modify anything to help improve her plaque index score. For appointment number 2, we'll be going over the left half instead, and it will be flossed as well. And it will touch back on the right side just to explore to see if there's any new calculus to be found that just needs to be scaled off on those localized areas. And then oral hygiene instructions will be addressed again to see if the patient is following through with the new modifications. For appointment 3, we'll be reevaluating within 6 weeks from appointment 2. She'll be probed, assessed for plaque index and marginal bleeding index to see the improvements. And as every other appointment, we'll be going oral hygiene instructors to discuss them to make sure it is being followed, to see what works, what doesn't work with the patient, what needs to be improved, and if we need to make any changes. For her reports, first 3 days were good. We did see that she did lack in protein and exceeded mainly on carbohydrates for her macromolecules. In order for the patient to balance her kilocalories, the patient will need to slightly decrease her carbohydrate intake and increase her protein intake. For the second set of 3 days, we do see that she made some slight modifications, but still not enough. She did still exceed in carbohydrates, but at least her lipids did increase a little bit so she could reach her goal. And according to the American Dietary Guidelines for Americans, the patient is required to consume between 1,800 to 2,400 calories a day. Unfortunately, my patient never met those goals only in day 1 of her 6 days. She consumed 2,014 calories that day. The other days were below the 1,800 calories. In order for the patient to reach her goal, she's going to have to be committed and continue to make those slight modifications that she was doing between these 3 days in order for her to reach her goal. For oral hygiene instructions, it's not much that we want her to modify. She's going to continue to brush and floss twice a day. We'll brush twice a day. Flossing, we want her to floss twice a day now. She'd only flossed once before, but now we want her to do twice so we can help that plaque index score between her and in between her teeth. We also want her to use Enta for her new implant. We want to make sure she takes good care of it. It's not rejected. Also, we want her to use interdental brushes on her facial lingual surfaces for her anterior teeth, especially that lingual undermandibular. We want to make sure it stays good because that's where we mainly found most of the calculus when we explored as well. She wants to continue to use fluoridated toothpaste. Also make sure it has whitening toothpaste because she does want her teeth whitened, so that will definitely help her improve her appearance. For the reevaluation, she did improve on her plaque index, which is amazing. She was before 82.29, and now she's at a 64, which is, wow, definitely more than the 10% that we expected to improve. Her bleeding marginal index Did improve slightly. It was 33 before, and now it's 26. Not big, but it's still better than what it was before. Her gingival tissue is also looking nice and healthy. No big changes. Mandibular gingival tissue was just pinkish reddish, but no big change. Still healthy. Probing 2 to 3 millimeters, still what we expected. Nothing too crazy. Although when we did explore the areas, we did find some calculus in between her anterior teeth and some in her third molars, but that's okay because we just scaled it right through and it was all good to go. Every other area was good to go. It was nice and smooth. And that was it. Thank you so much. Here are my references.